What are the limitations of CAR T-cell therapy? So it's my opinion that this has transformed the management of chemo-refractory large cell lymphoma. However, as I mentioned, only 40% of patients are having durability of their responses, which means 60% of patients will fail this therapy. So one of the current research efforts is to understand mechanisms of resistance so that maybe we can enhance upon that efficacy. There are also studies looking at utilization of this novel therapy in earlier lines of treatment. So there are currently 3 randomized studies in the US looking at CAR T-cell therapy versus salvage therapy in first relapse. And there are prospective studies even looking in earlier lines, meaning patients who are having early failures of frontline R-CHOP therapy. So that's one of the current questions is, can you apply this earlier? Will that overcome some of the resistance mechanisms? There are a lot of studies underway trying to understand CD19 loss and how that impacts resistance, particularly in the adult large cell lymphoma population, as well as the impact of the microenvironment on these T cells that may lead to exhaustion. So that's actively underway. And lastly, it may be dual targeting of antigens. That is one way to overcome antigen loss in lymphoma, such as targeting CD19 and CD22 as one example. So I think over the next few years, we'll have more data emerge that may address some of these limitations with CAR T. Lastly, I'll touch upon the availability of this. So not just can you generate an autologous CAR for patients, is manufacturing successful in the time frame we need it? Because these patients generally have highly proliferative tumors, and we're selecting out folks that have already failed standard treatments. So off-the-shelf CARs or allogeneic CARs that will be genetically modified, ideally removing the T-cell receptor, the endogenous T-cell receptor, are also efforts that are currently underway.